Well, good morning or good afternoon, everyone. I guess it really is. It's been interesting and beautiful day so far. I'm trying to get to my notes here. So here we go. Okay, so first off, my name is Daryl O'Sullivan, and I'm on the board of directors of the Western Neuropathy Association. And I want to again welcome you back to the conference. This is the 2021 Western Neuropathy 3-day annual conference, and it was from May 12th through the 14th, and all via Zoom. And we have reached across the whole country, which is phenomenal. So yesterday we had an excellent presentation on stem cells, and we discovered where we are all, where we're all from in terms of all the members and all the people who attended. Today and tomorrow we'll have, again, special guest speaker for the first hour, and the second hour will be open for you to ask questions and learn more about your neuropathy. Each day, the meeting will be facilitated by one of our executive board members, and you can attend today and tomorrow or either day, depending on how you feel about it. So today we're going to have a presentation by Dr. Manisha Korb from UC Irvine, and her talk's going to be on approaches to neuropathy. And then later, the second hour, we'll have a group discussion led by Bev Anderson, and we'll be talking about what do you do to help your neuropathy. And then tomorrow we will be having our guest speaker will be Barbara Montgomery, who will speak on nutrition. And then the second hour will be Julie Folligan, excuse me. Well, she'll give us an actual gentle yoga lesson, and that will end up being the conclusion to the conference. But the other thing I want you to be aware of is that this week is Neuropathy Awareness Week, and I encourage each of you to tell someone you meet or talk to about your neuropathy, so they understand that what you're suffering. And you should feel comfortable about doing that. The last thing I want to get to mention before we actually get on to talking and having the speaker give her presentation is just to remember that please keep your mics muted during the presentation. And then please feel free to add your comment or your questions to the chat. And at the end of the presentation, we'll go through the chat and answer all your questions as best as possible. And then we'll we'll finish that up and then move on to the second hour. So I think we'll get started. And so it's my absolute pleasure to introduce Dr. Manisha Korb, a physician more than a physician, a neurologist. She's at UC Irvine, and she specializes, as I said, in neuromuscular medicine. She's board certified in neurology and electrodiagnostic medicine. She completed her residency in neurology at the University of Chicago Medical Center, where she also served as the chief resident. I'm assuming that's in neurology. She also completed her fellowship in neurophysiology at the University of Chicago. She evaluates and treats patients in the neuromuscular clinic at UC Irvine. She mentors and teaches fellows and resident physicians and participates in clinical trials. Her clinical practice focuses on autonomic neuropathy. So without any further ado, I'd like to welcome Dr. Korb. Welcome, and you may please begin your presentation.
Thanks so much, Daryl. I really appreciate the introduction, and thank you everyone for being here today. I hope that this is an informative and fun discussion today, interactive as well when we get into the questions and answers. And so without further ado, I'll get started. My topic today is approach to neuropathy. Okay, so let me advance this. So we're gonna go over the types and patterns of neuropathy. We'll discuss different diagnostic approaches and procedures, review some treatment methods and some clinical trials that are ongoing. And also, if we have time, go over a couple cases so that we can work through what it's like to present with neuropathy at a doctor's office. So peripheral neuropathy is very, very common in neurology practice. And, we see it in general neurology. And then sometimes the cases get referred to us in neuromuscular medicine, where we are super specialized in neuropathy and disorders of the nerves and the muscles and the junctions between the nerves and the muscles. The prevalence of neuropathy does increase with age. And by age 80, about 30% of people have neuropathy. So even after age 30, you start to have a little bit of loss of those little axons, little pieces of the nerves, and that accelerates as you age. So each decade it increases, and by age 80, it's quite common. Now, how much of those people actually have symptoms from neuropathy is not as high as that whole number. But if you were to test electrically all of the people above age 80, a lot of them really would have neuropathy. There are over 200 different etiologies or causes of neuropathy. So a lot of the times we're able to identify them, but about a third of the time they remain idiopathic. And that's the word that you'll hear a lot in neurology. And you'll hear it in other fields of medicine as well, but neurology, we use it a lot because the nervous system is kind of that final frontier where, you know, we haven't figured everything out yet. Idiopathic means we don't know what's causing it. So unfortunately, it's either idiopathic or sometimes we'll call it cryptogenic. That happens even with strokes where, you know, we don't know exactly why a stroke happened. Same thing with some neuropathies. But if you're above age 50, we can safely say that it could also just be age related. And some people are more susceptible than others. Some people it happens a little earlier than others. If it's below age 50, then, you know, maybe we have to look a little bit deeper to see other possible causes though. The good news is that progression to non-ambulation or amputation is quite uncommon in your typical bread and butter, as we call them, your garden variety neuropathies. So this pie chart has a nice breakdown of a study that looked at over 2,600 patients that were hospital-based in many different hospitals for their causes of neuropathy. In general, about a third of your typical neuropathies are related to diabetes or blood sugar dysregulation. This chart here from this study said that 23% were idiopathic, although you'll see a lot of other studies say more like a third of them are also idiopathic. And then meanwhile, your other 1/3 of the pie chart is all the other little causes that can happen as well. So inflammatory, toxic, metabolic, and other inflammatory from connective tissue disease or vasculitis, vitamin deficiencies, which are in the nutritional deficiency category, things like thyroid, your liver, your kidney. If those are in disarray, those can contribute to a metabolic neuropathy. Hereditary neuropathies are quite rare. So, you know, red flags for that would be if you're a young age of onset, you had multiple family members with neuropathy. Those may be clues that there's something hereditary, but most cases are not. Connective tissue diseases include things like lupus and Sjogren's. Vasculitis basically is an inflammation of blood vessels, and that can lead to disrupted blood flow and oxygenation of the nerves, and then you can have neuropathy from that. Toxic causes could be from excessive alcohol use, for example, chemotherapies. Some of those are notorious for causing neuropathy, etc. Okay. And then we talk about the different patterns of neuropathy that you're going to see. So your typical neuropathy is a stocking glove distribution. So that's what you see in the far right picture here. We say stocking glove because the feet, where the longest nerve fibers are traveling down the body, are the most susceptible to any toxic and metabolic injuries. And so the feet are affected first in most neuropathies. As it gets to the upper shins, to the knees, sometimes the fingertips will be involved as well, and it'll sort of progress and ascend slowly in that stocking glove fashion. And then, you know, other patterns that we can see may be amyotrophy. So that's where a whole limb is involved, like a whole plexus. The plexus is a network of nerves that can run in the shoulder area towards the arm. That's called the brachial plexus. We also have the lumbosacral plexus, which feeds the nerves throughout the leg. So then that might be amyotrophy. A mononeuropathy multiplex is where you have individual peripheral branch nerves that are picked off, and that can happen with the vasculitis most commonly, or just a typical one nerve affected. A mononeuropathy can happen if there's focal compression or focal injury to a nerve. Other patterns we look for are, is it a sensory predominant issue where there's numbness, tingling? Is it motor predominant where it's more weakness or atrophy? Or is it both, sensory motor? Another pattern we have to look for is it axonal or demyelinating or nodal? So axonal means the core part of the nerve itself is involved. That's what transmits signals from one part of the body to the next. Or is it the insulating sheath that surrounds the nerve? That's called the myelin. Is that part affected? That's more common in some of the inflammatory conditions like Guillain-Barré syndrome. And then nodal neuropathies. So those are less common, but those are from an ion channel problem in the nodes between the little sections of myelin. And then, you know, I've sort of mentioned the anatomical patterns like length dependent, meaning stocking glove, or non-length dependent. Non-length dependent ones are a bit more patchy. They can be more close to the nerve roots. Nerve roots we call radiculopathy or polyradiculopathy. Multifocal patterns are like what I said with vasculitis as well. Another pattern we look for is it a small fiber or a large fiber problem? Large fiber nerves include those large myelinated nerve fibers, and myelinated meaning that insulating sheath again, which speeds up the conduction velocity across the nerve. So large fiber nerves include motor nerves, all motor nerves, so nerves that control muscle function, and sensory nerves that control joint position sense, you know, where is your finger or your foot in a space, or we call that proprioception. It also controls vibration sense. That's why your neurologist will test a tuning fork on your finger or your toe or a nearby bone and see if you can feel that vibration, because that's looking at large fiber function. Small fiber nerves are the little microscopic nerve fibers that run throughout the body that control pain and temperature sensation. So that's when we're checking with the pinprick or the cool side of a tuning fork along your skin and seeing if you feel that everywhere. Those are small fiber nerves. They also include autonomic nerve fibers. The autonomic nervous system is what controls things that are not under voluntary control in the body, like regulation of blood pressure and heart rate, the gastrointestinal, genitourinary, and sweating systems. And then a final pattern we look at is it hereditary, something that runs in the family, or is it acquired, something that you've developed on your own because of something either degenerative or inflammatory, etc. I mentioned also neuronopathies here. That's when you have dysfunction of the cell bodies of the nerves. So nerves, you know, start in the spinal cord and then they kind of extend out into the body. And where they start, it's called the cell body. That's kind of like the little tiny brain of the nerve, so to speak. And so for motor nerves, those are called anterior horn cells. And for sensory nerves, those are called the dorsal root ganglia. And so if those are disrupted, then the nerve dysfunction can be more severe, actually. So those are a non-length dependent type of neuropathy themselves. And we call them neuronopathies because of the cell body. Okay, and just to explain that axonal versus demyelinating a little bit more, here's an example where you see the cell body. I'm not sure if you can see my cursor moving, but the cell body is here up in pink, and the nucleus of the cell is in the little pink center in the center there. And then there's little branches that go out called dendrites, and those are what help nerves communicate with each other. And then the cell body extends out into this long yellow fiber down here, which is the axon. That's what transmits the signals. And it eventually reaches the muscle, because in this case, this is a motor nerve. And so there's a junction between the nerve and the muscle called the neuromuscular junction. And then you can see little oblong segments that are coating the nerve along the way. Those are called myelin. And between the sections of myelin, and again, myelin helps speed up the transmission of the signals. Between the segments of myelin, there are nodes of Ranvier. And those are where the action potential, the signal, can jump from one node to the next. So they can speed down along the nerve really fast. And so that happens in motor nerves and some larger sensory nerves. When you have a neuropathy, you have dysfunction of the axon or the myelin or both. And so if you have a disruption of the myelin, you can have secondary axonal degeneration. And if you have an axonal neuropathy, you can have secondary demyelination as well. So both of them can be affected, but usually it's one predominant part of either axon or myelin over the other. And so we try to tease those out with our nerve conduction studies. So let's start with axonal polyneuropathies, and then we'll talk about the demyelinating ones. The axonal polyneuropathies happen because there's a disruption to the metabolic state of either the anterior horn cells or the dorsal root ganglia, the cell bodies, and there's a problem with the axon transport. Axon transport is what carries different little molecules along the course of the nerve for nutrition of the nerve and support of the little organelles and proteins, the little pieces of the nerve inside of it. When there's disruption to any of those things, you end up with neuropathy. So this is a pretty large table with a lot of different esoteric types of causes of neuropathy broken down by acute and subacute, so very sudden onset. So acute means, within days or weeks. Subacute may be more weeks to a few months. Chronic would be more like years. So chronic kinds of neuropathy are more common. So diabetes is really up there. This is not exactly in the order of most common, but other common causes of chronic neuropathies are thyroid dysfunction, excessive alcohol use, idiopathic, especially age-related, as I mentioned. Charcot-Marie-Tooth is a type of hereditary neuropathy. Type 2 is your axonal types. Then there's different protein disorders like amyloid, where there's misfolded proteins that can infiltrate into the nerve fibers. There's hereditary neuropathies, and there's a few other hereditary ones I mentioned at the bottom of this that are quite rare. So anyway, we look for signs, but usually there's other parts of the nervous system and organ systems that are involved. It's not just a neuropathy by itself. In terms of the acute and subacute types of neuropathy, there are axonal variants of Guillain-Barré syndrome. So this stands for acute motor axonal neuropathy. There's also an AMSAN where there's a sensory motor component. Porphyria is a rare blood disorder where you can have neuropathy as well, but again, other organ systems will probably be involved. There's infections, there's drugs like chemotherapy, some antibiotics, toxins like heavy metals, vasculitis, like including Sjogren's, lupus, paraneoplastic, where there's a cancer that causes circulating antibodies that can affect the nerves. Infiltration, like with blood cancers or sarcoid. Amyloid, again, the misfolded proteins. Critical illness, where, if someone's in the ICU for weeks on intubation, ventilation, they may also develop a neuropathy as well. So there's so many different causes of axonal neuropathies. So it helps to break them down by the time course. Now, in terms of demyelinating neuropathies, these are much, much less common than axonal. The problem here is that there's a breakdown of the myelin sheath around the nerve that causes an exposed section of axon that can't propagate the action potential or the signal to go along that axon. Hereditary causes of demyelinating neuropathies could be from a problem of the structure of the myelin protein. And then acquired causes may be from gangliosides or these cell surface molecules on the nerves. Those molecules help the nerves talk to each other. So there may be antibodies attacking those gangliosides. All right, so much fewer causes of demyelinating neuropathies, but the most common things that you'll see are either a Guillain-Barré syndrome type picture where you have an inflammatory process affecting the myelin sheath. There's a chronic version of that as well called CIDP, chronic inflammatory demyelinating polyradiculoneuropathy, very, very long name. Other acute types of demyelinating neuropathies include one called multifocal motor neuropathy. So there's just motor nerves that are involved here. There's no numbness involved. Paraproteins, which are blood protein disorders, they can be acute or chronic, so they're on both sides. There's some hereditary ones like Charcot-Marie-Tooth that are demyelinating. That's a chronic thing if it's hereditary. And a few other rare hereditary disorders that I mentioned here as well. And also some toxic and infectious causes that can be more acute and affect the myelin. Okay, so a little bit more on hereditary neuropathies. There are over a couple hundred different genes that are identified, but honestly, the majority of patients still don't get an exact genotype. Things have improved a lot in the last 20 years in terms of genetic testing. Things that may make you think of a hereditary neuropathy would be a young onset, such as in childhood or early adulthood, like someone in their 20s, 30s at the most. Pretty rarely do we diagnose a Charcot-Marie-Tooth, a hereditary neuropathy in people who are, above age 50, but it can happen. There's dozens of different kinds of Charcot-Marie-Tooth hereditary neuropathies, and they're broken down by the inheritance pattern and whether axon or myelin is affected. A couple other hereditary neuropathies I'm mentioning here are involved with Fabry's disease, which is a storage disorder of the cells. But they also have involvement of their kidneys and their hearts. I mentioned Fabry's because they have an enzyme replacement therapy that can improve symptoms. So, you know, we definitely don't want to miss things that have treatments. The other one that's hereditary that has a treatment is called transthyretin amyloidosis, also called familial amyloid polyneuropathy, or FAP. And this is where you have these misfolded proteins that are infiltrating in different organs and nerves. And this one also has a couple drugs that just became FDA approved in the last 5 years, including inotersen and patisiran. So I mentioned these not because they're common, but because they have treatments out there. So they're notable. Okay, moving on to small fiber neuropathy. Again, just like large fiber neuropathy, a third of the time, these can be idiopathic. Still, the #1 cause is abnormal glucose metabolism, diabetes, prediabetes, etc. Other possible causes are the amyloid, the Fabry's, Sjogren's, which is an autoimmune condition, toxic causes like for medications, chemotherapy. So these manifest with burning, shooting, tingling, electrical pain. There can be reduced sweating function. I mentioned the autonomic nervous system can be a small fiber nerve problem, where there's impaired regulation of blood pressure and heart rate control. So when you're standing up, you may have a drop in your blood pressure. That's called orthostatic intolerance, and you can faint often. Impaired control of the blood vessels that feed the skin. So there can also be constipation, urinary retention, heat intolerance because of poor sweating. So again, this happens more in diabetic people, but can happen for many other causes as well. Okay, so how do you take a history for these patients? So we ask you, what are your symptoms exactly? You know, do you have numbness, tingling, burning, weakness, muscle atrophy, clumsiness, etc.? What is the time course? So is it acute, subacute, or chronic? Is it progressive, where things keep getting worse? Is it stepwise, where, you know, things are bad and then things are okay and stable for a while, then it suddenly gets worse and then it suddenly gets worse again? Or is it monophasic, where something bad just happened and you have a lot of symptoms, but then it's kind of stayed that way? Or does it come and go and relapse? What fiber types are involved? What is the pattern anatomically throughout the body? What is the nerve pathology, axonal, demyelinating, or mixed? Are there systemic findings of other organs being involved? Are there other medical comorbidities like diabetes or cancer, lupus, etc.? And those are all things that can be helpful as well and give us a clue as to why the neuropathy has happened. I mentioned celiac and IBD, so an inflammatory bowel disease. Those can be associated with a neuropathy as well. Exposure risks, so environmental exposures, you know, with heavy metals, lead, things like that. Occupational history as well. So there can be toxic chemicals. History of chemotherapy or prescription drugs can also predispose people to neuropathy. Certain recreational drugs and alcohol. For example, there's something called Whippets, which has some nitrous oxide in it, and people can inhale that and cause a really severe neuropathy. And a lot of teenagers who do this kind of thing don't know, and then they end up in the hospital. And then family history, and then if so, what is the inheritance pattern? Is it a dominant trait where every generation gets it, recessive where it skips generations, X-linked where it's gender-based, etc. On exam, we look at your sensory function. So we're going to look at small and large fiber nerve functions. So we'll test with pinprick, tuning fork for vibration, temperature, joint position sense. So, you know, can you feel where your fingertip or your toe is moving in space? Is it going down or up with your eyes closed? We look for sensory ataxia. There's something called pseudoathetosis, where you have these writhing movements of your hands. It's usually more the hands than anything, because of impaired joint position sense, and you cannot tell where your hand is. And so you're uncoordinated with that. This is pretty rare. Weakness, especially in the hands and the feet muscles. So we'll check your toes, we'll check your finger spread, finger extension, muscle atrophy, especially in the dorsal interosseous muscle, which is between your first finger and your thumb. That's commonly involved. Or the
audio on now.
Oh, I think everyone's supposed to be on mute until the questions, but okay. And then we check your reflexes with the reflex hammer and see if those are reduced. Typically the ankle jerks go away first in most neuropathies. And we look for any signs of ulcers, deformities like hammer toes, high arched feet. Those can be signs of a very chronic neuropathy, as you can see in that lower picture there. Then again, people can have hammer toes and high arched feet just for orthopedic reasons. So it doesn't necessarily mean that there's neuropathy. Sometimes we get referrals just because of those deformities and people assume they have neuropathy, but their nerve function is totally fine. But it also can be seen in chronic hereditary neuropathies as well. So we assess for those things. And hypertrophic nerves or enlarged nerves also can be seen in certain nerve conditions. Red flags that we look for are if this has started suddenly, an acute or subacute onset, if there's rapid progression, that's also not typical. If it's not length dependent, so not your stocking glove distribution, that's another red flag. If there's associated autonomic disorders, like recurrent fainting episodes, for example, if there's associated systemic disease, other organs are involved, and if you have more motor involvement than sensory involvement, that's also atypical. So those are all things that make us wonder, is something else going on? What can we do to figure out what's going on? Okay, so let's talk about workup. All right, so there are many different things we can do in our clinic. So blood work is usually the first thing that we check. Sometimes we'll do a nerve connection study, EMG, and I'm gonna have a slide on each of these things to go into more detail. Some patients will require a spinal tap, a nerve biopsy, skin biopsy, MRIs, autonomic testing, genetic testing, ultrasounds, etc. But the majority of patients don't require these things. We do them if they're clinically indicated and we have a clinical suspicion for something else going on. Routine labs that we check in all people coming in with symptoms of neuropathy include a vitamin B12, methylmalonic acid, which is related to B12 metabolism, blood sugar, and something called serum protein electrophoresis with immunofixation. And that's looking at blood proteins. Okay, other labs we may check, I'm not going to go through all of them, but we're looking at other inflammatory, infectious, metabolic markers, etc. Okay, so what is a nerve connection study and electromyography? We just call this EMG for short, but usually it's the two-part test where you have electrical stimulation of your nerves, the NCS part, and then a needle which goes into different muscles, and that's the EMG part. That tells you how well the nerve and the muscle are communicating with each other. The nerve connection study is important because it tells you if it's an axonal problem or a demyelinating problem, how severe, what's the anatomic distribution, etc. The main limitation is that it does not look at small fiber nerves, only large fiber nerves. The EMG will tell you if it's a neurogenic problem, so nerve related, or myopathic, meaning muscle related. If it's chronic, how severe, what's the anatomic distribution. Repeating the nerve connection study over time is usually not indicated, but it may show progression or improvement, say you've started treatment, etc. So on the bottom left, you see a picture of a nerve connection study where we're stimulating a nerve. And then on the bottom right, you see a needle going into a forearm muscle, assessing the muscle fibers. A nerve biopsy, people think that they need this, but this is a very last resort test. We very rarely do nerve biopsies. We only do them if we're really worried about vasculitis, to be honest. And vasculitis, again, is the inflammation of the blood vessels that feed the nerves. So we would do that if it was like a asymmetric, subacute, aggressive, maybe with weight loss or other systemic symptoms going on. So usually we do a nerve in the lower leg, and we may take a little piece of muscle along with it to look for other signs of inflammation. This picture here is what the nerve, the blood vessel looks like that's feeding a nerve under a microscope. And it's very abnormal because there's all these tiny little blue cells all around it, which are inflammatory cells. So this is what a vasculitic vessel might look like. Okay, a skin biopsy, however, is not invasive, and we do these more commonly. They're pretty simple. We just do a 3 millimeter punch in 3 sites in the leg. And this can tell us if there's a small fiber neuropathy. However, it will not tell you why you have a small fiber neuropathy. It'll just confirm what we already probably suspected clinically. So sometimes we don't do it because it may not change management. But basically what you see here is you'll see these tiny little small nerve fibers crossing from the dermis to the epidermis, the different layers of the skin in a normal person. And then someone with small fiber neuropathy, you're not seeing all those little nerve fibers. So if the density of those little nerve fibers, the IENFD, is low, then that's a sign of small fiber neuropathy. We do autonomic testing at my lab in UC Irvine as well. So this is looking at sweat function, heart rate, response to breathing exercises, and we do a tilt table that's looking at how your blood pressure and heart rate respond to being tilted upright. And this tells us also more about the autonomic nervous system and small nerve fibers. Again, not every patient needs this. It's only if you have autonomic symptoms. Nerve ultrasound, we also don't do very commonly, but this can actually be even better than an MRI. Usually MRI is the best imaging modality for deeper structures, but for superficial nerves, an ultrasound can be a cheap and pretty effective way to see if there's nerve pathology, a focal problem with a little mass that's compressing it, or a tight ligament around it, like with carpal tunnel. So for example, here, we're seeing in carpal tunnel syndrome, CTS, the nerve is actually enlarged compared to a normal person. So it's enlarged if there's problems with the blood flow and flow along the axon. So it's a little paradoxical that the nerve is bigger when it's compressed. And that's just, it's bigger distal to the site of compression. Okay, so how do we treat neuropathy? Once we've diagnosed it, it really depends on the underlying cause of neuropathy, okay? So if the cause is a toxic cause, like you've had someone with excessive alcohol use, they're drinking a case a day for the last 20 years, cut back on the alcohol, obviously not cold turkey, but slowly cut back. If it was because of a chemotherapy regimen, maybe you can try an alternative chemotherapy drug, or try to cut back on the dose, et cetera. So we try to work with the oncologist, but of course, treating the cancer is going to be more paramount than the problems with neuropathy, but we also do want to preserve quality of life. So that's for toxic. For metabolic, say it's a diabetes problem or thyroid disease, then you want to treat that metabolic derangement. And then theoretically, that could maybe help the state of the nerves. If it's a vitamin deficiency, like a B12 deficiency, then you're going to supplement that. If it's something immune mediated, an inflammatory disease like Guillain-Barré syndrome, then there's different immunosuppressive or immunomodulating drugs that we can use, including steroids. If it's something that's paraneoplastic or paraprotein related, those are related to different cancers or blood cancers, blood protein disorders, then you're going to treat those malignancies or plasma cell disorders. If it's hereditary, typically there's not really cures for hereditary neuropathies, with the exception of a couple things like Fabry's, like I mentioned earlier, where enzyme replacement therapy could be available, or for the amyloidosis, there's a couple neuropathy medications for that. And now if it's idiopathic, which is probably what a lot of people in the audience have, unfortunately, there's not a treatment per se, it's more symptom management. But there are a lot of ways to manage symptoms. So many of you are probably familiar with a lot of our neuropathic pain medications like gabapentin, pregabalin or Lyrica, duloxetine or Cymbalta, nortriptyline and amitriptyline, also called Pamelor and Elavil. Other pain medications like lidocaine patches, Voltaren gel, people use CBD oil. Then there's also anti-seizure drugs like carbamazepine. Those are kind of last resort because those are, more side effects typically. So there's a lot of different kinds of drugs we can use to control the burning, tingling, shooting. These drugs do not help return sensation. So if you have numbness, it's not going to help with numbness. It'll help with the positive symptoms like the burning, tingling, and shooting. And then there's, of course, other pain medications like narcotics, like oxycodone. We try to avoid those things because they're not as good for nerve pain. They're better for musculoskeletal pain. And also, they're addictive, they're sedating, and they're constipating. So they're not ideal to take on a long-term basis. Physical and occupational therapy are also mainstays of symptom management and working on quality of life. Some people with weakness and gait instability may require walkers or canes or ankle foot orthotics, AFOs, if you have foot drop, to stabilize the ankle joint. And then for some people, integrative rehab can be helpful, where there's a lot of different non-pharmacological, non-drug therapies that can be helpful, like massage and acupuncture, yoga, tai chi, biofeedback, pain psychology. All of these things may be helpful for people who are either maxed out on their drugs, or maybe they want to avoid medications. Maybe they want to do more natural things. So these things can be helpful for people's symptoms as well. And then, if you have foot ulcers, you're prone to knocking your feet into things, and then you should work on podiatry and proper foot care. And one of the number one things I'm always telling all my patients is that regular exercise is vital. A sedentary lifestyle can enhance the pain signals that you're receiving. It also can promote blood sugar dysregulations and problems with diabetes. And so for a number of reasons, being sedentary is actually worse for neuropathy. Of course, this is a vicious cycle, because if your feet hurt too much to be active, it can be difficult. So we understand that too. Okay, I've probably got about 8 minutes, so I'm going to kind of try to move quickly for the next few slides. Alpha lipoic acid is one of the supplements that's an antioxidant that has been shown in many clinical trials to improve nerve function and disability scores in terms of symptoms. Personally, when my patients take this, they don't usually notice too much improvement, but it is something that some people do like to take. Exercise, like I said, there have been so many studies showing that it does improve nerve function and symptoms in diabetic people, but also in people who were on chemotherapy. So not necessarily just for diabetic type neuropathies. So exercise is a good thing to do. It helps reduce inflammatory markers, etc. Charcot-Marie tooth, which is the hereditary neuropathy. I mentioned there were clinical trials we had at our hospital up to last year, where we were looking at a couple of specific types of CMT with what's called a myostatin inhibitor that was injected into the muscle. Unfortunately, it was terminated a year ago because it was not improving things. And then there's many different molecules that have been studied for Charcot-Marie tooth to help reduce that abnormal DNA or RNA level. So those are in the works as well. Okay, and I'll go through one case here, and I won't do the second case in the interest of time. So this is a 53-year-old man coming in with 1 year of progressive numbness and tingling in his feet. Sort of typical story. He feels that his balance is off, his feet are a little bit weak. And so what would you ask him next? So if he came to our clinic, we would wonder, do you have any other medical problems like diabetes, history of chemotherapy for a cancer, etc. And he says no to all of those. He doesn't take any medications. He never sees doctors. No family history of neuropathy. He does admit he drinks alcohol, maybe 3 beers a day. And we always tell ourselves, whatever the patient says for alcohol, it may be a little bit more, because we know that people may downplay things sometimes. So take that with a grain of salt. And then he says he does work a desk job and he is sedentary. So these are all some clues as to what might be going on. On exam, we noticed that he has reduced vibration sense and pinprick sense up to his ankles. He doesn't have ankle jerks on his reflexes with the hammer. And he has a little bit of weakness in bringing up the toes on both sides. Romberg's sign, which is when we ask him to stand up with his feet together and close his eyes and just stand still, is positive. So that means that once we ask him to do that, he sort of sways and he's very unsteady with his eyes closed. And so that's a sign that he has a proprioception problem, or the sensory input to his feet, knowing where his feet are in space, is impaired. Okay, so we do some basic workup and we see that his hemoglobin A1C, or the long-term marker for blood blood sugar control is elevated at 6.8, which is in the diabetic range. So he's diagnosed with type 2 diabetes, and he's counseled on diet and exercise, also counseled to cut back on his alcohol, separate from the A1C. After 3 months of conservative management, he improves to 6.5%. So just at the bottom of the diabetic cutoff. The cutoff is 6.4. Below that, 5.7 to 6.4 is pre-diabetes. So his primary care doctor starts him on metformin for diabetes control. And a year later, he's brought his A1C down to 5.8. So now it's at the bottom of pre-diabetes, almost at the normal range. So he's done a great job with that. Has not required insulin, which is great. But he still has some numbness and tingling in his feet. But fortunately, the neuropathy did not get any worse. He's not needing a cane or a walker. He's looking at his feet regularly for any signs of ulcers, and his feet are okay. He walks 3 miles a day, and he's working on a heart-healthy, low-sugar diet to keep his A1C in check. He's stopped drinking sodas. That was one of the big culprits for him. He's lost some weight. He's cut back on his alcohol, and he's doing a lot better. So this is improving his diabetes, helping preserve the health of the nerves. It's heart healthy as well. So it's good for a number of reasons. Okay, and we're gonna skip case 2 so I can allow for questions sooner. So let's skip that one. Let me just do the take home points. So what I want you to all remember from today is that neuropathy is very common. We see it all the time. I get multiple new patients every day in clinic with a primary complaint of neuropathy. I probably see more neuropathy than any of the other neuromuscular conditions. Usually your typical neuropathy does slowly progress over time, but most neuropathies are on the milder side. If there are signs that it's more aggressive, then we will look for other possible causes. The main diagnostic tests that we do are blood work and our nerve conduction studies and EMGs. There are some other diagnostic tests that we do for unusual cases. The treatment depends on the underlying cause of the neuropathy, but again, many cases are idiopathic. And in those cases, treatment is more supportive and symptom management. The best things to do are to optimize your nerve health are a proper diet, including proper blood sugar control, avoiding excessive alcohol, getting proper exercise, as tolerated, aside from the neuropathic pain, and avoiding being too sedentary. Also, we need to rule out other sources of pain and numbness and weakness. So, I mean, neuropathy is not the only thing that can cause pain. There's also, orthopedic issues, joint issues, fibromyalgia, etc. So we want to make sure that we're teasing those out because some of those are not the same thing. Also, there could be other causes for numbness, like there could be pinched nerve roots or something in the brain or spinal cord. So we want to rule out those. And usually with a history and physical, we can distinguish. And weakness as well. We want to make sure that there's not other causes for weakness aside from the neuropathy. Not all of these things are just from neuropathy. So all of those are important for your doctor to figure out for you. All right, that's it for my talk. I'm happy to answer any questions.
Well, thank you very much. That was an excellent talk, and you covered everything in a real good detail, and I think it should help us understand a lot. So I'm going to open up the chat box now and sort of ask the questions that are listed here as best I can. So I'll go all the way to the beginning. There was a question that said, did you state that demyelinated neuropathy is uncommon?
Yes, demyelinating neuropathies are very uncommon. I would say at least 90% of neuropathies are axonal. Primary demyelinating neuropathies are much less common.
Okay, the next one is, can you discuss spinal cord stenosis? My understanding is that cervical spine myelopathy can cause of neuropathy like symptoms, pain, burning, etc. in arms and legs and feet.
Yeah, so spinal stenosis is the fancy way of saying that there's narrowing of the canal where the spinal cord runs through. So if the vertebrae, the bones surrounding the spinal cord are tightening up, there's arthritic changes. So we call it degenerative disc disease. So there's like flattening of those discs that are supposed to cushion between the vertebrae. And then there's little bony osteophytes, like little shards of bones that start sticking out. All of those things can sort of tighten the space where the cord is running. when you compress the spinal cord with a disc herniation, for example, you can have myelopathy, which is dysfunction of the spinal cord. But the symptoms are going to be most likely different from just neuropathy. Like, yes, you can have numbness and weakness from a myelopathy, but you'll also probably have brisk reflexes versus neuropathy will have decreased reflexes. Often myelopathy also may be asymmetric, unlike neuropathy, which is usually symmetric. Sometimes there can be problems with bowel and bladder function as well in myelopathy. So there's different things that can distinguish them and clinically, and then of course, imaging with an MRI or a CT scan of the cervical spine, lumbar spine also can help you distinguish between those.
Thank you. Next one is if someone never sweats, is that part of neuropathy?
Sometimes. I mean, there's many different reasons for having sweating disorders, and neuropathy is probably one of the less common reasons to not sweat. But you will find, for example, with a diabetic person with neuropathy that they may have less sweating in their feet, and maybe they'll have more sweating higher up to compensate for the less sweating further down. But there's other reasons too, like dermatological reasons, where you may have reduced sweat function.
Okay, next is, what does it mean when you have a stepwise symptom pattern?
So for example, if you have a vasculitis and you have a mononeuropathy multiplex, so you have one nerve in your hand that's knocked out, and then you have one nerve in your leg that's knocked out. So, you know, you have symptoms of this hand, and then months later, symptoms in your leg, and then months later, symptoms in the other hand. That's stepwise.
Okay. Next is, why does neuropathy in my feet flare up when I sit or lay in a reclined position? I also have a herniated disc L5 with radical pathology or radiocopathy. Or I'm not saying that right.
You mean radiographic pathology, or?
No, it's radical.
Oh, radiculopathy.
Radiculopathy. Okay, yeah. Okay.
Yeah.
I just didn't say it right.
No, that's just pinching of the nerve roots. So that can happen with the degenerative disc disease. So yeah, a lot of people do complain that their symptoms are worse when they're laying down, like when they're going to bed, or when they're sitting with their feet elevated. You know, it could be related to just the positioning. Maybe the nerves are stretched in a different way. Sometimes it's worse at nighttime because, you know, you've been up on your feet all day and then suddenly you're laying down and your mind is not distracted with other activities anymore. And so you're noticing those pain signals more as well, or it's just built up, accumulated from the day's activities. Often people do say that it's worse at night.
So the next one is, about 4 or 5 years ago, I was diagnosed with idiopathic small fiber neuropathy. I periodically notice that slowly I lose some feeling in the bottom of my feet. More problematically, every few months, mostly my left foot has intense stabbing or tingling pain. After a few weeks, it goes away. What is happening in these intense periods? Is it likely that the relapsing will continue or will become constant?
Well, first of all, I should say a disclaimer. I don't want to provide, you know, direct medical advice or diagnoses for anyone here, because, you know, your doctor has to examine you and get a good history and physical, etc. So that's the main disclaimer. Just based on hearing that, I would say, you know, small fiber and large fiber neuropathies can have fluctuating symptoms. You can have good days and bad days, good weeks and bad weeks. And, you know, sometimes there are flare-ups as well, where symptoms will be a lot more prominent. And that's not atypical.
Okay. Next, I'm 78 years old. I was a practicing alcoholic for about 20 years. Daily consumption was 25 ounces. I got sober 41 years ago. Neuropathy was diagnosed around 2005. So I'm not sure what the question really is.
Okay. Yeah, again, and you know, people do ask us how much alcohol is too much alcohol. So I'll just answer that question that I am telling you a lot of people ask me. And I would say we don't have a good clear cutoff for that. There's not like there's studies that say, a certain number. But we generally say for women, 1 drink a day is okay. For men, up to 2 drinks a day. Beyond that, it might be in the excessive range. People have different thresholds for where that amount of alcohol is going to tip them over and cause organ problems, like with your liver or with your nerves, with your brain, etc. So excessive alcohol just in general is not good for your body or for your nerves. But usually it takes a good amount of persistent alcohol use for years to develop organ issues.
Okay, thank you. Next is for the skin biopsy. As I understand it, a score less than 10 indicates SFN. Do the real active scores mean anything to a clinician that is a score of 2 versus 8?
So it's not really a score so much as the density of the small nerve fibers. The numbers are going to vary based on your gender and your age. So when the little skin biopsy samples are sent off to the lab, there's a couple of different major labs. There's one in Texas, one in New York that are the most commonly used ones for looking at skin biopsies. They're going to look at age matched controls and gender matched controls and which anatomic sites were used. And so those numbers are going to be different depending on all of those factors. So that's the best way to answer that.
Okay, thank you. In 2014, unfortunately, I had a sural nerve biopsy. The outcome is a combo of numbness and foot pain. Will other foot nerves change post-sural nerve biopsy?
No, yeah. So unfortunately, when you take a biopsy of a nerve, which again is a very last resort thing, we don't take out nerves unless we really are worried about something like vasculitis. You remove a piece of nerve that will never grow back. So generally, we only do it if you're already numb in that area anyway. So you're not going to increase the deficits that you already have. It is unfortunate to take out a piece of nerve when you had sensation before, and then now you're lowering that, but it shouldn't affect other nerves. The biopsy that was just on that one nerve is just going to affect that one nerve.
Okay, thank you. Where to go or do if tripping, stubbing toes all the time? And then in part of that is curving under of the toes normal with neuropathy?
Yeah, so the toes can sort of curl under. They're called hammer toes. That can happen when there's a chronic neuropathy because there's weakness of the intrinsic foot muscles that extend the toes. So then you get unopposed action of the flexor muscles of the toes. So they curl under. It can also happen, like I said, from orthopedic issues and just, bone structure, that's personal to you. Maybe it runs in the family. That's just how the toes are for you or people in your family. So it doesn't have to be from neuropathy. Neuropathy can make you prone to stubbing your toes into things more often because you can't feel where your feet are. So the best things are trying physical therapy for gait training, balance training. If you have unstable ankle joints with foot drop, then ankle foot orthotics can be helpful. Sometimes canes or walking sticks can also be helpful.
Okay, thank you. The next one is, I was diagnosed with idiopathic small fiber neuropathy. I suspected low B12 as a cause. Levels were in the low 200s. My neurologist said that low B12 does not cause SFN. Would you agree? Also, my neurologist said that causes of PN will many times be multifactorial.
Yeah, I agree with both of those. So, so low B12, and I would say low 200s is in the low range. Low B12 can cause neuropathy. So I would say a B12 supplement can be helpful for some people. So if you take it for, say, 2-3 months and then recheck the level, see if it's improved, it may help symptoms. And then, sorry, the other question was, oh yeah, they can be multifactorial. That's absolutely true. There can be multiple reasons for having neuropathy.
Okay. Last one on the list is, what kind specialty of neurological doctor could one seek if neuropathy is the main issue? You mentioned that you see more patients with neuropathy than other colleagues.
Yeah, so neuromuscular neurology which is what my field is the one that treats neuropathies. So neurology has maybe 8 different subfields. So there's neuroimmunology, which is things like multiple sclerosis. There's memory disorders, dementia, Alzheimer's. There's movement disorders, which is things like Parkinson's. There's neurootology, which is inner ear disorders, neuroophthalmology for eye disorders, stroke, epilepsy, maybe a couple other ones, headache, and then general neurology, and then neuromuscular neurology. Neuromuscular means we treat nerves, muscles, and everything in between the nerves and muscles. So that would be your main place to go if your general neurologist finds that there might be something more to be evaluated.
Okay, a couple more popped up. Can hammer toes be helped by increasing arch support?
Yeah, I would say go to a physical therapist. Sometimes an orthotic specialist can help with foot inserts or shoe inserts to help stabilize the feet and the toes more.
And the last one is, Bev is asking, if you have time and you feel comfortable, can you do case 2?
Oh yeah, sure. Okay, so yeah, we have a few minutes.
Yeah, I think so.
Okay, so case 2. So this is a 67-year-old woman who's coming in with progressive numbness that started in her fingers and then it spread to her thighs. So already you're seeing a non-length dependent pattern. So hands and then legs. So that's atypical. And it's happened over just 4 weeks. So that's a subacute to acute sort of time course. She also says that she has a lot of pain throughout the muscles in her body, but that's been going on for several years. On exam, she has profound loss of vibratory sense with the tuning fork in all of her arms and legs, impaired proprioception, which is the joint position sense in the hands and the feet. She has patchy loss to pinprick and temperature sensation, pseudoathetosis, which is the writhing movements of the hands because she can't feel where they are in space. Areflexia, so we test with a reflex hammer throughout the body, and she does not have reflexes anywhere. And ataxic gait, which means when she's walking, she's kind of walking like a drunk person, like stumbling side to side. That's ataxia. So this is a pretty bad exam, pretty severe, nerve problems here. So we check some labs. So we look for things like Sjogren's disease, vitamin B1, which is thiamine, HIV. Those are all things that can affect the sensory neurons, the dorsal root ganglia, because her exam is indicative of a sensory neuronopathy. So this is not your typical sensory motor neuropathy or stocking glove neuropathy. This is something more severe that's involving the dorsal root ganglia. The nerve conduction study and EMG confirmed that she does have sensory neuronopathy. And so we are more aggressive with our workup in her case because of all those red flags. So she has some chest imaging and she is found to have a small cell carcinoma lung cancer that's been biopsied. And so we check for things like a paraneoplastic panel. Paraneoplastic means antibodies that are circulating in the body produced by a tumor, by a cancer. And so in her case, she was found to have anti-Hu antibodies. Those are a kind of antibody that can cause encephalitis or encephalopathy, so like brain dysfunction. They can cause neuropathy and neuronopathy, which is what she has in her case. They can cause a lot of different nervous system dysfunction. So she was found to have that. So for her, treatment of the underlying cause, the lung cancer, was key. So treating, so resecting the tumor, treating with chemo and radiation, and just treating the cancer itself helps improve her sensory symptoms. It may not help everyone's sensory symptoms with a paraneoplastic disorder, but for her, it did help somewhat. However, she does still have these muscle pains throughout her body, and it turns out she also has fibromyalgia. So that's separate from her sensory neuronopathy. And the fibromyalgia is not going to necessarily respond to the cancer treatment. That's a separate condition. Basically, fibromyalgia is a chronic pain disorder where all of your blood work and imaging, exam findings are all normal, but it can still be a very debilitating condition that really severely affects your quality of life and your function. There are different medications that can help that, and some of them have overlap with neuropathic pain medications like Lyrica. And for her, that was helpful. So that was just going along with my take-home point that not all pain is from neuropathy. Some pain is from different causes like arthritis or fibromyalgia, etc. So we always have to help try to tease those out. And that's it for case 2. Any other questions? Daryl, anything else?
I have a question.
Sure.
Wait a minute now. Okay, so let me just jump in here. I'm sorry, I had my mic muted. It
Okay.
says, can gabapentin and Cymbalta be taken together?
Yes. Those are 2 that I like to give together when dual therapy is needed.
Okay, and then the last one I have on the screen is, with small fiber neuropathy, why would increased exercise cause increased delayed pain?
So increased exercise can help for a number of reasons. So 1, it reduces those circulating inflammatory markers in the blood. 2, it helps with that central sensitization of pain signals. So people with chronic pain disorders, whether it's from small fiber neuropathy or something else, they're constantly getting these pain signals sent to the brain, and it's a very complex pathway for pain sensation. And exercise actually helps remodel those pathways and helps reduce those pain signals. Also, if you are exercising, then theoretically you're also controlling the blood sugar dysregulation, which some people may be prone to. And so it helps promote the health of the nerves in that way as well.
Okay, so I have a caller who's had a question. Is the caller online? Can I hear?
Yes, sir, I can hear.
Yes.
Can I get your slides of your presentation, which was super good?
Yes, yeah.
Yeah, we will have that all on the Western Neuropathy website, and you'll be able to get all the information.
Yeah.
So lastly, gabapentin and Lyrica can be taken together, question mark.
Oh, gabapentin and Lyrica should not be taken together just because those have the same essential mechanism of action. So they both work in the same way to calm down the nervous system. So if you're taking both, you're just going to be sleepier, and it's better to maximize and optimize the dose of one of them and not be on both of them. I said that you can be on duloxetine, Cymbalta with gabapentin because those work differently. So that's okay.
Okay, so I'm going to ask the caller to ask their question again.
Yes, for chemo-induced neuropathy, can you have I guess, can it go in remission and come back, the neuropathy? And is that pretty much a permanent once you've been diagnosed with neuropathy 6 months past treatment?
Yeah, so there are some chemotherapy medications that can cause neuropathy months after the chemotherapy has stopped. That's called a coasting effect, where there's continued nerve dysfunction that happens later. It's not as many drugs that do that, though. So some of the platinum-based chemotherapies, for example, are known for being able to do that. But usually, if symptoms went away for months or years and then came back, then you have to wonder, is there something new that's affecting the nerves, not just the chemotherapy? And then the other thing is, if you have chemotherapy-induced neuropathy, do the nerves improve with time? Sometimes they can improve with time once the drug has been removed, but sometimes that neuropathy will stay there. It just depends.
Thank you.
Okay, but it's not very common for it to come and go if it's
no, that would be atypical.
Okay, thank you.
Okay, so I think we should close the session at this time. Okay. And I want